Good evening. I'm Ashley Reef. I'm the nurse coordinator for the Adult Congenital Heart Disease program at Houston Methodist, and we're happy to have you here for DeBakey CV Live. We have a very unique and exciting program for you this evening. We're going to be discussing ACHD transplant from a patient's perspective. We have two very special guests with us. First, we have Keshia Foxworth. She is a social worker in the Methodist Transplant Center, and she works exclusively with our ACHD patient population. Thanks for joining us, Keshia.
Thank you so much, Ashley. I'm excited to be here and excited about this talk tonight.
We also have Tina Daigle. She is our very special guest. She's an ACHD patient as well as a recent transplant recipient, and also, very interestingly, a nurse practitioner. So we're happy to have you here, Tina. Thanks for joining us and for being willing to share your story.
Well, thank you for giving me the opportunity to share, and I hope that my story helps other people.
For sure. We want tonight to be interactive, so please be sure to send us your questions, and we'll get to them as we follow along with Tina's transplant journey. All you have to do is text DeBakey to the phone number 37607. That's DEBAKEY to 37607, and we'll be happy to answer your questions. Our objectives for the program tonight, we want to discuss preparation for transplant in the ACHD population. We would like to talk about transplant outcomes in ACHD transplant patients in comparison with their acquired heart failure counterparts. And finally, we want to talk about the differences in listing of ACHD transplant patients. So with those in mind, let's get started. So Tina, we're going to put you in the hot seat right away. Tell us what your cardiac defect is and when you were diagnosed.
I have detransposition of DTGA, and I was diagnosed at birth.
Okay, and how were you diagnosed? What symptoms did you have?
My mom told me this morning that I was a blue baby.
Okay.
That I flew, and they knew that something was wrong with me when I was born, and she wanted me to go through the whole thing about how they brought me home, and I had heart failure and came back right now.
For sure. We want to hear all the details.
When I talked to y'all the other day, I actually have found out more. My mom told me that after 4 days, they had to bring me back to the hospital because I couldn't breathe. So then they put me on digitalis, and then they sent me back home. And at 2 weeks old, my grandmother came over and saw me and said, she's losing weight, don't need to bring her back to the doctor. So they brought me back to the hospital, and I think that was the point where I got so sick that they brought me to Houston by ambulance. My mom said it was the most horrible ride of her life. But they were flying down the interstate from Louisiana to Houston. And when they got me here again, I think it was 7 weeks. I was 7 weeks old. I guess they kept me in the hospital for about a month. And then they did a surgery to keep me alive, which was the Blaylock handling. I think that's how you say it.
Yep.
And then they sent me back home and told my mom and them I wasn't going to live because there was nothing for me at that time. That was 1963.
Okay. And then how many surgeries have you had overall?
Those two, Blaylock handling and then the mustard at 3 years old.
Okay. And then I know you've had a lot of other interventions. I know we discussed that when we spoke the other day for sure. But I know about 90% of children that are born with congenital heart defects are now living to adulthood. So I know we talked previously about your transition from the pediatric care to adult care. So talk about that a little bit and just kind of what you saw as the benefits with that, and maybe what were some things that were a little bit more difficult for you.
That happened pretty late down the road when I was probably 40 or so, and they were trying to get me into an adult congenital clinic. Probably, it was okay, because it was the same place and the same doctors. But when I transferred to Methodist, it was a little different because it was a pediatric setting, and there were things that happened at the pediatric hospitals, like when you went to CAF and stuff like that, that they do much differently. The medications, and when you're in the hospital, they do much differently. So when I came to Methodist, it was much easier for me. Now, I've heard stories that it's much harder for some because you put you to sleep for cardiac catheterization in a pediatric hospital. And when it's the adult hospital, you're awake. And I like being awake because I'm also a nurse practitioner and I was able to understand what was going on. And I don't like getting put to sleep because I had heart failure when I went to sleep because they'd give me fluids.
Right.
And then my blood pressures were always low. And they're like, oh, our blood pressure's low, give her fluids. And I didn't like that because then I'd come out with heart failure.
And what did you see as some of the benefits of shifting over to the adult world?
Being in an adult world, I understood what was going on because it was like, over here, well, the first time that Dr. Lynn did my cath, I was like, oh, this is so easy. It was such a relief.
Right.
And, I'm able to see what's going on and hear what's going on. And I also think that they don't get quite as upset.
The doctors don't get quite as upset?
Well, not the doctors, but the caregivers. Like at the peds hospital, you're 50 years old and you're in a pediatric ICU, and it's kind of like, what do we do with this person? It would be like me being an adult person taking care of a child. I don't know what to do with this.
Well, I can tell you I've been in that situation, coming from being a pediatric ICU, cardiac ICU nurse. I have been in that situation where I've had that adult patient, and I'll tell you, at that time, that's exactly what I thought. What do I do with this patient? So that probably is very true, very true. So what advice would you give to a patient coming in and making that transition? How do you think they can make that an easier transition?
I guess talk with the team and the doctors, a lot. Try to write down your questions, find out what's different. I think there's people that, like Keshia, saw me early in the process, and it was easy to talk to her and to find out, well, what's this and what's that, and then just try to. You can even talk to the pediatric people sometimes because they gave us a lot of advice too about moving over. It's going to be different, which I already knew, but I think that just remember you're going to have to learn everything new. Like you have to learn your doctors, you have to learn the process, you have to learn everything and advocate for yourself when you go because you know yourself.
And what about from a medical professional standpoint? What do you think what things can we do better to help people make that transition?
Well, there's a couple of things that, were brought up when we had our support group meetings. And one that I thought was to understand that we have been through a lot. Many of us more. I don't feel like I have been through that much. But many of us that I've listened to talk, they have been through a lot. And there's a certain amount of untrust, I guess, and trauma that comes with that because you've been hurt for a long time. You hurt every time you go in the hospital. That was my biggest thing. I never wanted to go to the hospital because when you go in the hospital, you're going to hurt.
Right.
They're not going to mean to, but they're going to hurt you.
Sure.
And so I think remembering that all these doctors surround you, and I can't imagine, I don't remember it as a child, but I know as an adult, it would get kind of like, I just want to tell my story once.
Right.
But I think the people that we talk in the support group, they get scared because they were young and they get scared and they have all these people around them. And, it's kind of scary when a bunch of people in white coats come in, I guess, For me, being that I was one of the white coats, it was like, I didn't, you look at it from two different ways. Right.
And Keshia, I'm sure with a lot of our patients, you encounter that very same thing with them making that transition. Are those a lot of the same things that you hear from patients?
Yes, and as Tina alluded to, we've talked about medical trauma. In fact, I believe that was our last topic of discussion in our last support group meeting, just addressing the medical trauma reference. And one of the patients said, well, I never considered that it was trauma. You know, I knew I had some anxiety, and I knew I seemed to become more stressful when certain procedures were recommended, but I didn't even realize that this is what I'm actually dealing with. And so we just kind of unpack that in the support group and allow patients to process their feelings. And sometimes patients feel like they need some additional therapy. And so whether they contact me by phone or, shoot me a quick email and say, hey, I think I do want to reach out to that therapist that you talked about in the support group the other night. Can you pass that information on to me? And so some patients just didn't know what the term was. They didn't understand it. And so, but we do see that a lot in our patient population.
And I can't tell you again, Keshia, I know I tell you a lot, but we definitely appreciate having you around to be able to help those patients make that transition.
I'm happy to be a part.
And Tina, I know now we talked about you moving from the pediatric to the adult world, but what about you getting pregnant and having children of your own?
So that was a traumatic event for me then. I didn't know, because this is kind of strange to say, but from the time I was about 6 years old until I was 23, I didn't go back to a cardiologist, which is one of the things I find very strange, that we never came back. And so I didn't know a lot of the things that I shouldn't do. Like now I know. Maybe then I shouldn't have gotten pregnant. They told me when I got there, once I found out I was pregnant, you need to go to Houston. So then I came over here and they told me that I couldn't have the baby, that, it wasn't possible for me to have a child. And I'm a little bit on the hard-headed side. So I decided they didn't know. And so I did go to a doctor that said he would try. And it was actually what it called high-risk pregnancy. So he said he would try. And then along with the cardiologist, they worked with me. But when I was, I think, 5 weeks pregnant, maybe I'm, it kind of gets fuzzy back there. But when I was 5 weeks pregnant, they said you need a pacemaker. Well, it's kind of hard to get a pacemaker when you're pregnant. You got to use radiation. And so they did it by echo. And then they got me past the arrhythmia points, which has been a problem most of my life. The arrhythmias, probably all of my life. But we ended up, they said, okay, we'll do it. They put the pacemaker in, and the rest of the pregnancy went well. But it was very scary and traumatic to go through all of that and them tell me you can't do this. And I just couldn't understand. And I guess at that time they just didn't know. But now at this time, people are having babies. And it's so, I think for me, it's like, okay, Tina, you might have been one of the first ones that opened this door for these people. And to me, that is so good that, they could learn from my experience, and then they could have more babies.
Well, definitely, we encounter a lot of patients that, have that desire to have a baby. And, of course, we're always willing to work with them and be frank with them about their ability to safely have a baby. So you are one of those trailblazers for sure.
Well, I was 23, and that was in 1987, 88. So,
okay.
Yeah.
So let's fast forward a little bit to when were you first told that you needed to have a transplant? How old were you?
Well, the first time probably in 40s.
Okay.
And
Okay.
we went through the whole, I think that was in 97. I had a really bad problem, a pacemaker issue where they had to pull a lead.
Okay.
And I was under for 13 hours. And I think it was somewhere around in there that they first mentioned the transplant word. And then a few years later, they gave me a packet.
Well, what was your first thought when you heard that transplant word?
I don't think so. I need to go back to work.
And how about when they finally gave you that packet? What was, same thing?
Well, the second time when they gave me the packet, I was like, But then the third time was when I really knew that I had the problem, that I need to really think about this. And so I'd had 2 episodes of heart failure around, actually it was 3. There was one in 2012 when I was driving home and had it on the side of the road, which was a bit scary. But anyway, got through it and came home, and then said, I need to go back to work again. And then 2018, I had an episode and they got me out of it real quick. And then 2019 was the big one. I was working, had worked a lot. We had lost some of our people. They left or whatever. So we were working too much, and I worked too many hours, and I got a bad heart failure, and I ended up staying home for 4 days. And also, not to mention, I had also gone into AFib and they couldn't get me out of it. So I stayed home for about 4 days, and then it was time to go back to work. And I said, I can't do it. So I stayed home 2 more days. And then on the Wednesday, I can tell you it was Wednesday, I went to work and I couldn't walk down the hall. So I was like, and I was supposed to work in the hospital, and it's a very big hospital. And so I couldn't go, I said, well, if y'all put me in the clinic, I'll do the clinic. So I did the whole day in the clinic. I think even one of my patients told me I didn't look good. And then I tried to walk back to the office, and it was really hard to get back. And I was not doing well, and I had to sit. And so when I left that afternoon to go home, I didn't know if I could walk across the street without getting run over. So that's when I said, I guess it's time. So that night I went home, I tried to sleep, couldn't sleep. The next day, my daughter, I said, bring me to the hospital. We did a TE cardioversion, didn't work. They put me on milrinone for about maybe 24 hours, 48 hours. And I started having PVCs. And I decided that I didn't want to be on milrinone anymore. I was getting rid of the fluid and everything was good. So I was like, I don't think I need to be on milrinone right now. And my doctor said, okay, Tina, we'll take you off of it, but I think it's time you start. We look for somewhere to send you for a transplant. And so that's kind of how that all happened.
Okay, and then so obviously that was the turning point when you, the professional and personal Tina, decided it was time for transplant, since your doctors had been telling you for a while, right? And then kind of talk us through what happened from there. So I know you went to another transplant center initially, right?
Yeah, I went to another transplant center, and they told me that there was an issue with my IVC that had to be opened before I even could be a candidate. Well, that got opened, and then they just said I was too high risk, and they thought I might need heart and lung. So then I came to Methodist and saw Dr. McElry, and that was the first person I saw, which I was so grateful because, over there, the other place, I didn't see the surgeon at all. And so that kind of made a big difference to me, was that if the surgeon accepts me, then hopefully everything will go well with everybody else. And when he told me he could do it, we cried. I mean, that was very traumatic for us. It was like, oh, thank you. And so then after that, we saw Dr. Lynn, and I had the heart cath. And then there was a lump in my neck, which was a thyroid nodule, and I had to have that biopsy. And then after that, it was the colonoscopy. And then I got listed on February 28th. On March the 2nd, I got a call, couldn't have it because of some technical issues that I couldn't take the heart. And then on May the 13th, I got the call, and May the 15th, I got my heart. So after the heart transplant. Should I go into that now?
No, I think we'll get to that. We're going to focus a little bit more on just your journey getting evaluated for transplant. So I know you said you saw Dr. McGillivray with CV surgery. Who else did you see as part of the multidisciplinary team while you were being worked up?
I saw the GI doctor. I saw the pulmonary doctor. I saw, who else did I see? Endocrine, because I also have diabetes. So we had to work on both of those. Who else did I see? Oh, I had cataract surgery too. And I forgot about that. That was in, I think that was in March, right before everything shut down for the COVID. The day before, I had my second eye done. So I think that's all of them. Sure. And then the transplant team.
Right, of course. And then research shows that a patient that is evaluated in a medium to large volume transplant center that has expertise in ACHD surgery and transplant has a much better outcome than those that are seen at smaller transplant centers. So I know we as a team work closely with specific members of the hepatology team and nephrology. You mentioned pulmonology. So it sounds like you saw the gamut of our specialized team for sure. So just to move into kind of during your transplant, while you were making that transition and you got that call, I guess Keshia, will you talk a little bit about the kind of the psychosocial side of that progression with you? I know you worked with Tina closely during that time.
Right. Actually, Tina did not have many psychosocial challenges. As I've seen with some of our patients, what my role is as the ACHD social worker is to, again, we offer a comprehensive approach in our clinic. And so we want to make sure that we address any psychosocial barriers, whether that's concerns for the support people that are included in that circle of care for patients pre and post transplant, whether there are some financial concerns related to insurance or the ability to cover the expenses related to transplant. And so what my role is to make sure that patients are, I'm the liaison, if you will, between ACHD and the transplant team to help patients get ready to be presented to the medical review board to make sure that they will be an ideal candidate. Tina, again, didn't present with many psychosocial challenges. We did have some talks about her advanced care plan, and I'll allow her to speak a little bit about that. But part of the transplant process is that you have an advance directive in place. And so, Tina, can you just share the dilemmas about that when you and I spoke back in February about that?
Sure. So as they wanted me to do an advance directive, and I'm like, well, I don't know. Me and my daughter, who's also a nurse, has talked about this extensively. And so I asked for, some information to help me go through this process. And she gave me some information, which was a bunch of questions about quality of life. And it took me, I didn't think it would take that long for me to make these decisions and to see, what I wanted to do, because I knew that I didn't want to be left on a ventilator forever and, not, if something happened, blah, 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 if I had a stroke or whatever, I didn't want to be like that. So it goes into the qualities of life on this questionnaire, and I felt like it was very difficult to go through answering the questions and seeing yourself as not here or what you want. And so it took me forever to go through these questions, and I didn't finish it. I got my transplant first, and I didn't sign the advance directive until I got into the hospital. And I signed it, and I thought, what does all that other stuff matter? I want to live. So I'm just going to sign this directive and say, I don't want, any other measures done if I'm seen as brain dead or whatever. So I just signed the paper and thought, I'm going in this to live, not to die. So that's how I got to the end of my dilemma, and it was kind of solved for me because, I just knew I wanted to live.
Yeah, and it is a difficult conversation to have with family. And what I try to do is encourage patients to start thinking about it early. It's not one of those conversations where I want to come in the clinic room and meet a patient and have the conversation right before they're getting ready to have some type of transcatheter intervention. So we want to try to introduce those conversations early. And what I do is I do provide information to patients so that they can visit what they think that should look like in the event that they can't make a decision based on injury or illness early enough. And sometimes it doesn't always happen as early as we like, as Tina mentioned. But you made the decision, as you said, you went into it with the positive notion that you do want to live and not die.
Yeah.
And Keshia, do you find that the big challenge, similar to what Tina had pointed out, is making those individual decisions about what somebody does and does not want versus just a general kind of overall advanced directive sort of planning? Like, do you think it's more difficult as they go through each individual, I don't want to be intubated, or I don't want this in this situation?
Right. I do think that, and it's just because we tend to not want to have conversations about our own demise. But I do think that having the conversation early is probably one of the best gifts that you can give your family members, particularly because it helps to reduce the stress and anxiety and the burden on your family. Especially in the height of our current health crisis, a lot of family members were faced with making decisions about their loved ones. Which I'm sure added to their stress level. And so, as best as we can, as early as we can, to sit down and have that conversation. There's a tool called the Conversation Project that's out there if you all are familiar with it. And so this tool has a starter kit, if you will. And it is similar to what Tina mentioned about asking questions. And what it does is identify your values. Do you want someone to make the medical choices for you? Do you just want to be in control of your medical choices? And so the Conversation Project is a good tool if anyone wants to visit that website and download that starter kit to ask those questions about end of life care in the event that it happens to be that case, because of course there's always risk with any type of surgical procedure. And also, it allows family members to really know your wishes so that it can help reduce some of that burden and anxiety from their plate.
And Keshia, you really visit with all of our patients about those sort of issues, correct? When you are meeting them in clinic?
Yes, and particularly I try to also focus on those that I know are having certain procedures, but I do try to introduce that conversation early, especially when I see patients who are unmarried. By law in Texas, of course, if a person is married, their spouse is that authority. But especially when I see younger patients who are over the age of 18, their parents are not the ones that are making the decisions for them. I do try to have that conversation with them. And it's still, I know they probably think it's kind of early, but it's never too early to have the conversation at all.
And Tina, I know you were talking with your daughter about it, and I think you're both probably lucky in one sense that you're both nurses, and I think you both understand what goes into all those things. But did you see that as kind of making it a little bit harder as well? In making the decisions of what you wanted and what you didn't want?
I think what made me more comfortable about the decision I made when I made it was that I had spoke to Stacy, my daughter, ad nauseum about this. We used to make up scenarios, and not as a game or anything. It was just what if, and she'd come home from work one day and say, if this happens to me, I don't want blah, blah, blah. And so we knew each other's wishes about our medical, and I made her the power of attorney so that I knew that she would know my wishes. We've talked about it a lot, and she would make those decisions when the time came. And she also had a lot of support from my family who were there with her. So, you know, I felt like she was going to be able to make the decision. And I think that's important to say when you're looking for somebody to make those decisions, because I could have used multiple members of my family. I did go through that process because I didn't want to give it to somebody that I didn't think would be able to make it. There are certain people that just couldn't do it.
Right.
Right.
You make an excellent point. You definitely want to identify someone that's going to carry out your wishes, someone who is not going to perhaps feel the pressure from other family members to influence a decision one way or the other that does not reflect what your desires are. So that's an excellent point, Tina.
And I think I agree with that. I mean, I totally echo that it needs to be had with not just that person who's going to be the person making your decisions, but with everyone in your family, I think, because I know in my experience, I've seen where there is a decision maker that is making the decision that the patient had indicated, but other family members are saying, no, that wouldn't be what he or she wanted. So I think that's a really fantastic point to really make sure that it's a very open conversation. Now I know, Tina, you didn't wait long for your transplant, but most research shows that congenital patients have a much longer wait time. They tend to wait longer just to be listed, but also tend to wait longer on the wait list itself. So how long did you wait?
The first organ was 2 days.
Okay.
2 days. The second one was from February to May.
Okay.
So,
and how in February, how did that I guess it was March that was the first part. So at March, when that had to be turned down, what was going through your mind? What were the emotions going through there?
So I don't think I was ready for it because I was with a friend at a movie when they called me, and I started crying, and I'm like, oh, and I just got very upset, and I had to call the coordinator back, and I really don't think that I was ready for that yet. And when we drove home and we got home and I started thinking about this, I really wasn't upset. I wasn't mad. I was like, thank you, because there was a relief. And that made me crazy because you're waiting for a heart, and if you don't get it, maybe that's kind of nutty to think that way, but I think it was just, I wasn't in the mental place for it yet. And that prepared me for the next one. The next one I had to do by myself because it was COVID.
Right.
And it just made me, okay, well, this is how it's got to go, blah, blah, blah. But there was a little bit of, what if it never happens again? Because, of course, there's that fear. But then I just said, well, you just got to keep on going, and hopefully it'll come along again. And there was a lot of praying. But that's, so when it happened, it was like, then I had to function, and I was able to function.
So did you feel like between that first and that second that it maybe changed your view on getting the new heart a little bit, that you kind of knew you were in and, ready, more prepared, I guess, to have that offer come?
I think it was just that it was 2 days after I got listed. It's gonna happen this quick. I was expecting like you say, most people wait a long time. And then the fact that it was from Friday to Monday, I wasn't prepared, I guess. And then those extra months there, it made it real. It made it like it happened already. So yeah, it's probably gonna happen again, which maybe I was thinking wrong, but it made it real. And then there would be days when I didn't get that other heart, maybe I won't get one. You know, it's just a process of up and down, but when it came the second time, I was ready for it. I was ready to go. I mean, it was hard leaving my house, leaving my dog, not being able to have my daughter there with me. It was hard.
Yeah, what was that journey like to be in the midst of COVID, to be getting a transplant? I mean, most transplant patients have a support system with them at least part of the time when they're undergoing all of that. What was that like being really by yourself?
Well, Stacy was allowed to come the day of, so I went on Wednesday. She was with me, I think, she was with me on Thursday night into Friday whenever they actually did the surgery. I don't remember exactly when she came back, when she came to the hospital. The other thing was that they wouldn't let me see my mom. So I told them I was going to go outside and see my mom. They said, that's fine, but she can't come in here. So they let me go out and tell my mom and my sister, talk to my mom and my sister for a little while. And then that was really, it was hard before the transplant. I think after the transplant, it was hard also because I was on the phone all the time. The nurses, they're like, you talk on the phone more than anybody I've ever seen. So after the transplant, I focused a lot on trying to get myself to walk and to do things. And because it took my mind off of nobody's here.
And what kind of support did you get from the hospital team, from our team, from the transplant team while you were in there, just due to the COVID situation?
The nurses were fantastic. The doctors too, they came. I mean, I think that it wasn't anything different than you would get if you were a normal patient in a normal time in the hospital. I think, they have the mask, but we wear a mask in the hospital a lot. We don't necessarily wear them in the room, but, we had the mask and they were able to come in and take care of me and do things. And,
Sure.
And that was good. And all people were sent.
Did you get to visit with Keshia while you were in there for your transplant?
I think several times, huh, Keshia?
Yes.
She would come visit me. Dr. Lynn's nurse would come visit me. Dr. Lamb. There was people, all kind of people coming in and visited me. There was I think that, the people from the coordinators came. So there was a lot of in and out. It was good to be able to talk to them and be able to find out what's next. There's a lot of questions after transplant. One of the biggest was, what can I eat? What can I not eat? What's going to happen next? So.
And I think that's just a continuation of that multidisciplinary approach that, everybody, it doesn't just end when you get the transplant. That's, you're going to see that team, at least the core part of it, forever. You're going to be with us forever. You're stuck with us. So tell us a little bit more about kind of post-transplant and as you were getting better in the hospital and as you initially left the hospital.
I think post-transplant was, like I said, on the phone a lot. I tried to walk a lot. It was trying to get into, and the medicines were pretty difficult to deal with. Because you get hot flashes, you shake, you do all kinds of things like that. Crazy things are happening to your body. And so that was difficult, but I tried as hard as I could to just keep walking. And I slept a lot. I slept in the chair a lot. I didn't want to lay in the bed. So I have a thing about staying in the bed. I was like, I don't want to get pneumonia, so I sit in the chair all the time and sleep. A lot of phone calls, that was a good thing. That kept my mind off of things. I went home, I think 2 weeks after the transplant, and the medicines make you, like the steroids, you really don't realize what they do to you until you're lower down on it. And I've had to have 2 bouts of steroids, of high-dose steroids, and that was one of the hardest things for me because my personality and my feelings changed. Sometimes and they said this, you'll be good one day and the next day you'll be crying and the next day you'll be mad. And there were some family issues that, I think that a lot of it was the medications and the way I was feeling at the time. And, they say that I read the books and said, you may have difficulties dealing with people, blah, blah, blah. And dealing with your circumstances. I mean, part of my big issue is I don't want to do nothing. And I couldn't do anything. I couldn't really do anything. I would shake and I would have to sit in my chair, and I didn't want to do that. I wanted to get up and move and be able to do my own stuff and be independent. And, it's kind of hard to do stuff when you're shaking and everything falls out of your hands. So that was, one of the problems. And plus, you're not as weak. Not as strong, you're weak.
So we have a question. So Tina, have you noticed improvement in quality of life that you haven't had in a long time?
Yes. I am now walking 3 miles a day, and I get up in the morning and I'm feeling great. I feel great. I feel almost like I used to when I wasn't sick. There is no coughing. There is no, feeling the fullness in my chest. I can go walk and, get up in the morning and do what I want to do. Today I'm cooking, getting myself too fat because I didn't realize that at some point, I got so skinny and now I'm gaining all the weight back and now I have to start watching what I eat again. So I'm like, okay, here we go again. Let's find something more healthy than this. But, at first I was so skinny and needing to eat because I hadn't been eating so long and I got sick, and then, the post-transplant even I got a little bit of problems and lost weight, and now I'm starting to get fat. So I have to do something. But I feel great now. I feel really good.
That's
and
good.
Everybody that sees me say, "Oh, you look so much better."
Well,
I guess I probably didn't.
That's a large change from not being able to walk across the street, for sure.
And not being able to eat.
Right. So tell us about you mentioned having some issues post-transplant. So elaborate on that a little bit. What kind of post-transplant issues did you encounter?
Well, one of the medicines made me sick, gave me stomach issues. And it got to the point that I got dehydrated and couldn't eat. It was making me feel bad. And so the stomach issues, they thought were because of this certain medicine. So then and also my white blood cell count went down, very low. And so they had to back off the medicines. And when they backed off the medicines, my levels from a Prograf went down. And so I went to the doctor and they said, okay, well, we're going to do a cath on the next, I think it was the next, we were going to do a cath soon. And I don't remember what the timing was. Or we did the cath, and then when I went back to get the results, the biopsy was a 2R. I had some rejection. Well, because of the fact that I had to come down so low on both of my rejection medications because of my stomach issues, they put me back in the hospital and gave me another 3,000 milligrams of steroids. And then I had to kind of start all over with the steroid weed. But most of the issues are stomach issues, and I couldn't. I remember going to the doctor and saying, you got to do something, because if you don't, I'm coming back and we can go in the hospital, because I was really feeling bad.
And research has also shown that the morbidity and mortality is increased in the immediate post-transplant period for adult congenital patients. And I know a lot of the issues that tend to lead to that, pulmonary hypertension, you never encountered that. Did you post-transplant? You didn't have any right heart issues because of increased pulmonary vascular resistance?
No, they didn't. They didn't. I didn't have right heart issues because of that. In fact, but Dr. Lynn did look at a. They have a, I guess, fistula. They have a connection between the pulmonary and the aorta, and he was worried about that, so we did a CT to look at that. And then recently, I had. This is weird. I had a bubble in my eye. And my bubble in my eye was really gross. And so I went to the eye doctor, and the eye doctor thought it was increased, like some kind of venous increased pressure in the eyes. And she was afraid there was something in my neck. And so my last cath was done. They checked my SVC because they thought there was some narrowing. There was a small amount of narrowing, but it wasn't bad. My blood pressures, it was finally thought that my blood pressures might be causing some of this too. Well, I think they said it could be possible. Got on more blood pressure medicines, and the eye doesn't look as bad, and the headaches have gone away. I had bad headaches. So it was probably a combination of everything, but the pulmonary hypertension, I think, is okay. Everything's good there. Okay. I didn't have any issues with pulmonary hypertension, and at this point, he doesn't think that fistula needs to be fixed. We're just going to monitor it.
And I know there often we'll see increased either intraoperative or postoperative bleeding in ACHD transplant patients, but you didn't encounter that either, correct?
Correct, and that in fact is why I didn't get the first transplant, because I was on Eliquis because of the arrhythmias. So from what I know, no, I didn't have any bleeding, increased bleeding. I was fine. I mean, seems like I've been very fortunate in all of this.
For sure, for sure. And I'm sure being younger certainly helps.
Yeah.
So
My body's not that young.
well, it's had a lot of surgeries, but for sure. But so Keshia, tell us about some of the things that you are doing with our post-transplant patients, and even just some of our ACHD patients. And I know Tina is highly involved in this with our support groups.
Yes, so we have a monthly support group that is virtual. I facilitate those support groups the first Thursday of each month. And so we actually initiated the support group during the height of COVID, just to serve as a source of support for our patient population during this critical time. And so it's a real intimate setting where patients hop on a Zoom call, and we allow patients to share their stories. And I believe our very first call, we had a patient that said that I had not met another patient with a congenital heart defect before. And so it serves as a sense of community for our patients. And sometimes we just, patients just allow patients tell their stories. And sometimes I'll have where I do either discussions on medical trauma, coping strategies for anxiety or stress, what depression looks like, when you need to seek further intervention by way of a clinical therapist, and whatever patients feel like they want to share. Some of our patients talk about how the feelings associated with being a guinea pig impacted them, and how they still deal with that even to this day. We had one of our patients that shared how all the white coats would come in the room, and especially if it's a unique defect, and how she felt not wanting to be the center of attention as a child, and how that has impacted her. So we talk about things like that in the support group setting. And so it's really open to anyone who feels like they need some additional support. Some patients don't want to get on a Zoom call, and that's perfectly okay. What we do offer is peer-to-peer support. And so if a patient is having some anxiety about having some transcatheter interventions, having those procedures, I've offered, Tina has actually volunteered to be able to talk to patients just so patients can have an idea of what that looks like going into that particular procedure.
And Tina, I know you're very highly involved with the support groups. What do you see as not only what's positive for you, but what is also positive, what you can share with our other patients, and what's positive for them about that?
I think that a lot of times we only think we're going through it, We're the only one that feels that way. And for me, to hear these people feel the same way as me, or I say something and they say, I'm glad you said that. It makes me, no one else around me in my family can understand those feelings. Because those feelings are the feelings that I only have went through. And there's not that many of us. So if you can find other people, then there's obviously going to be a support and an acknowledgement of yourself, of this is not unusual to feel this way, because these other people have been through the same thing and they feel that way too.
Right. And what success for me looks like is when patients connect offline, when patients exchange contact information and they don't feel like they have to wait until the support group is facilitated by me at the first of the month, but they're still talking outside of the support group. That's the greatest impact for me, because if they feel like they need that additional support in the interim, they can reach out and talk to each other.
And I think that's just really fantastic for our patients. I think since you've started doing that, Keshia, I think that has really, really helped so many people. And Tina, you are just, you are such a wealth of information for our patients, for sure. But we do have a question. So given this experience, what do you recommend parents of kids with ACHD do to make sure they can stay well as long as possible and have a healthy adulthood? So you want me to start? I got a long clinical list. So number one, educate in an age-appropriate manner your child as far as what their defect is. Even my patients now that I educate, I tell them they need to be smarter than the doctor that they're going to see. Certainly we try to arm them with the knowledge of this is your defect, these are the things you should and shouldn't do. But certainly it's very easy for one of our patients to show up in an emergency room. And this can happen in childhood or adulthood, and to be dealing with a physician that does not understand their defect. So in addition to that, make sure that your child is attending all of their cardiology follow-ups. And even if you're told that they are fixed or repaired, that you're continuing to have them follow up with a cardiologist. And that, because truly they're going to need to be followed by a cardiologist for life. It won't necessarily have to be at the same interval that they're followed in childhood or when they're undergoing intervention, but they have to be monitored. And it really should be somebody that has specialization in congenital heart disease. I also tell my patients as they get older, now this would apply more to an older adolescent, would be to keep a binder of any kind of information, especially operative notes of the procedures that you've had, most recent imaging, even sometimes most recent labs, up-to-date medication list. These are the things that really, even I give my patients pictures of what their defect looks like and carry that around. There's also, people can do it electronically. They put it on a thumb drive and they can carry it with them, have multiple copies. Certainly when you go out of town, make sure that you have a copy with you in case you end up in a hospital that is away from home. And one of the most important things is to make sure you have the contact information for your congenital physician, so that whatever doctor you're seeing, if you're in that ER, you can hand them that card and say, this is my doctor, call him or her, and they can tell you what I can and can't have. So I know from a clinical standpoint, from a nurse standpoint, those are the big things that I really teach my patients. So how about you, Tina? What do you say from a patient standpoint? What do you think are the most important things for those parents of children going through this?
Know their doctor, be able to call their doctor, know their medications. I think their medications, you know, in certain situations, like I go to the dentist, and you got to go to the dentist with take your buy antibiotics, and I don't know what the recommendations are for all. You know, for mine, I'm pretty sure that I still was supposed to be taking antibiotics, and as I got problems, more arrhythmias with my heart, the dentist scared me to death because they gave the medicine that made the heart rate go up. So I would tell them, no epi, please. My mom, and I am speaking from the parent standpoint of when a long time ago, my mom always told me she just wanted me to be able to keep up with my brothers and sisters, which I'm not sure if that's what y'all recommend now, but she wanted me to have a normal life. So she didn't hover over me all the time. In fact, she thought it was fixed and I was okay. But, you know, they didn't have the knowledge again that they have now. So now I'm sure that's common to tell them she's not necessarily completely fixed. You know, she's going to need, you know, follow-ups and stuff like that. So,
I think sometimes you'll still encounter that term fixed, or, you know, parents even maybe not being told that expressly, but believing, you know, okay, she had these surgeries and that's what this pediatric surgeon told me that she needed to have. So that must mean we're fixed. I think as far as being able to have a normal life, that is so important. I think that's, you know, probably why you got to the point where you were able to become a nurse practitioner and really, you know, able to have a very normal life. I think that should be everybody's goal with congenital patients moving from, you know, childhood to adulthood. And a great number of our patients live very normal lives. You would never know that they are a congenital patient. So I think that is another very, very important thing for parents to be able to do. How about you, Keshia? What would you say to parents?
Well, I think with our patient population, when especially for patients when they come into our clinic and they are re-educated about the lifelong diagnosis of their congenital heart defect, and they're made aware of potential future surgeries or transcatheter interventions, with that can potentially come some stress and anxiety. And so I think the biggest asset for this patient population is the social support. Having family around, having trusted friends around, and having a medical team that involves a comprehensive care for treatment for this patient population, and being able to refer patients as needed and provide those resources and tools that's going to help them manage their quality of life as best as they can.
Okay. And we have one final question. There are so many transplant programs in the country. How do you choose? So the most important thing about if you are a congenital patient choosing a transplant program is to find a center that is very well versed in doing congenital transplant, and has a complete multidisciplinary team to manage those patients, not just maybe a surgeon that has the experience, but you want to look for someone that has a respected adult congenital heart program, and you want to look for a surgeon that has a lot of experience with the complications that are unique to adult congenital surgery. And of course, you want to look for those consulting services, like Tina had to see other services for her when she was awaiting transplant, that really are also good at dealing with that congenital population. And, you know, I know we have a kind of pre-MRB multidisciplinary conference. and we really discuss whatever of those consulting services happen to affect that individual patient. And that's prior to them going to MRB, so that we can really prepare them to be best listed with the best chances of getting their heart transplant. So ladies, that is the end of our time. So we've reached the end of our hour, and this has been an amazing discussion. Tina, first of all, I'd love to thank you for joining us and telling us and our audience your great story. I'd like to thank DeBakey Education for giving us the opportunity to highlight this really important topic. And I'd like to definitely thank everyone that's joined us today. And we look forward to seeing you in the future for CV Live to discuss more about our unique patient population. So have a good evening.
Have a good evening.
Good evening.